Shokar. It is an honor and privilege for me to welcome you on behalf of Sun Pharma Bangladesh Limited for joining this live webinar on first endoscopy session 8. This is the culmination of an endeavor to integrate evidence-based medicine clinical practice, primarily in the field of hepatology, with most learning points illustrated from the point of view of day-to-day practice. Program promises highly interactive and practical. Endoscopy Masterclass is an initiative planned to arrange with effective, improving their expertise in the field of therapeutic endoscopy. The program is organized by Sun Pharma in association with Asian Institute of Physiology and Forum for the Study of the Medical University Autoimmune Alumni Association. First of all, I would like to thank you all for all your hard work and support. For humility, kindness. Sun Pharma consists of conducting different academic and scientific learning, and as a many here in healthcare sector have always valued commitment and their latest scientific innovation has been directed of today. Our privilege to have Dr. Rajesh Gupta, consultant gastroenterologist, Director Clinical Services, AIG Hospitals, Hyderabad, India, and Dr. Jagdish, Senior Interventional Radiologist, AIG Hospital, Hyderabad, and Professor Dr. Mamunal Mahtab, Department of Hepatitis, or P. I especially thank Dr. M.A. Rohit, Medical College, and Dr. Mohammad Alam Fatkar, of the department, and Dr. Alam, Department of Hepatitis of Bangladesh, for our also thank Dr. Syed Abdul Farid, Department of Physiology, AIG College, and the Department of Working Medical College, and integrating that. Now I invite Dr. Endra. Thank you. Unmute your. Thank you.
Can you hear me?
Yes, yes.
Good morning. I am Dr. Mohammad Abdul Malik College and Secretary, Hepatology Alumni Association, Bangabandhu Sheikh Medical University. Welcome to you all to this masterclass. And it's sponsored by Sun Pharma. I thank all the organization and all the participants and all the organizers. Thank you. I wish good webinar to this day. Thank you to you all.
you, Dr. Abdul Rahim, Associate Professor and Head, Department of Hepatology, Abdul Malik Ukil Medical College, Noakhali, Bangladesh. Now I like to invite our honorable speakers. First of all, I like to invite Dr. Rajesh Gupta, Senior Consultant, Gastroenterology and Hepatology, and Director of Clinical Services, Asian Institute of Gastroenterology, Hyderabad, India, to deliver his speech on hepatocellular carcinoma, a systemic approach to management. I'd like to invite Dr. Rajesh Gupta to deliver his speech.
Good morning, friends. Thank you, Dr. Saeed and Professor Abdul Rahim for the kind words. At the outset, I would like to thank Bangladesh Society of Liver Disease and for giving me this opportunity to share my thoughts on HCC, a systematic approach to management. Yes, right. Full screen. Just a minute. Having problem with full screen. Just make it full screen. Yeah. So, as you all of you are aware that in our part of the world, HCC is a major problem, and all of us come across the patients who suffer from hepatocellular carcinoma, and in our part of the world, hepatitis B is the major cause for HCC, and of course, as you all of you are aware, it's more common in men and important cause of mortality all over the world. In fact, it is the fourth most common cause of cancer-related mortality, and the incidence is steadily rising. And by 2030, believe that it could become the third most common cause of liver-related leading cause of death. So, with these, we can understand the seriousness of this problem. So, whatever systems there are to plan the management of HCC, especially to have a systematic approach to management, we must understand first the etiology of the liver disease, and secondly, what are the factors which can cause, what are the system, how we can classify the severity of the disease. It is based on the staging. And the stages, what we have, the different staging system, they decides whether the patient is operable or inoperable, because if we are in a stage of operability, that offers the best cure. So, with that word, we must understand the several systems of classification staging systems have been devised all over the world, which factor into the pathological, but they don't factor in the pathological stage of the disease majority of the time, and they don't capture other parameters. And we have several classification system or staging system, both Asian as well as European. In Asia, predominantly we have Hong Kong liver cancer staging program, and then of course we have Chinese and we have Japanese system of classification. In addition to have the European system, which is predominantly Bclc, CLIP, and French. But for the sake of discussion, I'm going to primarily focus on the Bclc system, which was developed in Spain and which is the most validated system. And I'm going to compare it with Hong Kong liver cancer staging system with our Indian experience, like Indian Association of Study of Liver Disease has come out with its own modification based on the stages of the disease. If you look at this chart, this is a very standard chart which all of us come across every day in, day out. And as you see, this is the Bclc class staging system of HCC. If you look at this chart, we can clearly see that early stage disease, that is 0 and stage A, they have clear-cut definition for operability, and this is the stage of the disease which gives us the maximum possibility of cure. I mean, more than 70% 5-year survival. Whereas if you see the stage D disease, which is basically best standard of care, where the survival is approximately 3 months. So, but here is because HCC is a very heterogeneous disease. As per the Bclc stage in system, stage B or stage at C, that is at intermediate stage and advanced stage of disease, here the prognosis or the overall survival, 5-year-old survives quite variable. And here the lot of development is happening all over the world to improve the survival. Now we have several intervention in this particular stage, which has clearly shown the survival advantage, disease-free survival. And I'm primarily going to focus on these two stages, that is intermediate stage and advanced stage. So how this system works? So Bclc system is primarily designed based on the performance state of the patients. If the patient has good performance status, means 0 and 1, obviously they have a better chance for further intervention. The second important factor is the presence of the liver condition. What are the liver function? The patient whether has advanced liver, whether the child C status is there or child A status there. That will influence the treatment plan, obviously. And third is the tumor burden, or what size of the tumor is there, whether the single nodule, multiple nodule. So this is another. So primarily this system is designed based on 3 factors, that is the performance status, liver functions and tumor state. Now look it further. But this system, as I said, is very rigid. It means it classifies that if you are intermediate stage or advanced stage, in intermediate stage you have basically chemoembolization strategies which give you median survival of 12 to 14 months. And if you have advanced disease, you have systemic chemotherapy, and that is approved is sorafenib. That was basically included long back in 2008 in Bclc amendment. But now, if you look at the data carefully in all these studies, there is a large group of patients who are, as per the Bclc stage, they are in B and C, but still there is a possibility of intervention, and this group is very large and heterogeneous. So basically the Hong Kong system Hong Kong staging system has tried to improve upon the Bclc staging system. So what they have done is they have tried to factor in other things also, like intravascular invasion and extrahepatic metastasis, because these are two important prognostic factors, the two important factors which influence the treatment decision making. If there is a intravascular invasion, the decision is going to be different. If there is a no intravascular invasion, there is no extrahepatic spread in spite of the size of the tumor, which takes you into the stage C, and it can influence the treatment. For example, if as in Bclc we see there is an early stage, it is less than single nodule, less than 3 nodules or intravascular pneumonia. It's early stage disease as per the Bclc staging system also. But this group is quite heterogeneous. But if you have single lesion less than 5 centimeter, if you have multiple nodules less than 3 centimeter, but the size is still fitting into the malign criteria, but there is an intravascular invasion. So will it be stage A? No. So it automatically goes into stage C. So we have these kind of heterogeneity in both in Bclc, and which the Bclc system fails to identify. So to improve upon that, the Hong Kong system has tried to include these patients. So a little bit, this is the Hong Kong classification of the staging of the liver system. If you see, they have taken into factor this both performance status and the liver function by child A and child B, and whereas the other group is advanced, this is a poor performance status along with the child C. Here also, if the patient is, and obviously if there is advanced tumors and with poor performance status, child C, this requires this as Bclc, it is stage D, and they are given best supportive care. Okay, but in this same group, if we have poor performance status but poor liver function, but the tumor is small, so it comes into stage 5 advanced stage as per the best supportive care, stage D as per the BCLC, but in Hong Kong it comes into 5A, which is further classified, and it can be, these patients can be offered liver transplant. So this is one important issue comes over here. But now look at this further classification. HK, Hong Kong system classifies not in intermediate stage and advanced stage into 2A and 2B and 3A and 3B. The reason being because the treatment strategy will vary depending upon the which stage the patient falls into. Say for example, in the intermediate stage 2, Hong Kong stage 2, intermediate 2, these patients, if there is no intravascular invasion, no extrahepatic metastasis, these patients can be offered resection, which offers a clear advantage of chemoembolization. Similarly, in locally advanced stage disease, which is stage 3 as per the BCLC, and these patients can be combined, both you can be down, these patients can be downstage and can be offered resection, which offers a clear advantage of the chemoembolization. So this is the clear distinction which we have come across with the modification or with the improvement of BCLC staging system by Hong Kong system over BCLC system. Now, what this is essentially what I have, this slides explain what I have just said. So here is the chart which just shows that BCLC stage B patients who were classified Hong Kong stage 2, they shows that if you offer radical therapies just compared to chemoembolization, the TACE, so there is a clear-cut 5-year advantage, and they are shown that the 5-year survival is 52% vis-a-vis 19% with TACE. So this is a substantial improvement, and this justifies that these patients should be reclassified. Similarly, in BCLC C stage, where they offer systemic chemotherapy, here this Hong Kong classification, revised classification, we see that this radical therapies, they offer clear advantage over systemic therapy, and they've shown that the 5-year survival is 49%, whereas there is no 5-year survival as per the BCLC stage C. So these are the clear advantage of reclassifying the things. This is a just simply explanation. I am trying to explain the Hong Kong advantage of Hong Kong system over the BCLC system, which we commonly follow. So what it essentially does, Hong Kong staging system, it's a multifocal tumor, intravascular invasion, which were not considered contraindication for surgical resection, which have been included in this group of patients. There are tumors, but they have tried to identify the tumors which are large. In our earlier, we were saying the tumor which are less than 3 centimeter, 2 to 3 centimeters, they should be recommended ablation as a curative. But it is not so. You can extend this limit up to 5 centimeters. So, third important thing, if somebody who is having tumor, but there is evidence of intravascular invasion and intrahepatic invasion, there are no contraindication to chemoembolization therapy, intraarterial therapies, because we have newer modality. We can consider these patients for those kind of treatment. So, essentially what it states that you have to be a little more aggressive, especially in intermediate stage and advanced, locally advanced disease. That is stage B and C, Hong Kong BCLC system. But the problem with Hong Kong staging system is there is no external validation, because BCLC has been widely validated, especially in Western population, which is not the case with Hong Kong system. And primarily it is a retrospective data, and thirdly, there is a considerable overlap of the survival. And obviously there is some authors believe that there is because we have primarily, the systems have primarily focused on taste, so there is unintentional biases there. Now coming to the another important system, which is for the Asian population, that is APSL based, APSL proposed HCC system. Here essentially they have tried to slightly simplify the things. So whether the patients have portal vein patent or portal vein thrombosis there. And then you have to factor in the child status A and B. If the patient has child C with portal vein thrombosis, obviously you only advanced disease, you have to offer them systemic therapy or best support. But if the patients have no portal vein invasion, if the main portal vein is patent, if the patients had good liver function status, then you can offer resection, and you can, small lesion, you can do ablation therapy also.
Sir, you got disconnected. Mayank?
Yes, Mr. Satya.
The Indian Society of,
Yeah, okay. He's back.
sorry, I lost this. Uh, uh, Sorry for the interruption. Come back. So now looking at the Indian Association has made some modification.
Please share the PPT, sir.
Can you hear me?
We can't see the presentation.
You can see.
You need to share the presentation.
Okay, I'm just coming and I think we lost this. So essentially, can you see now?
No, sir.
I am just Varun. 1 minute urgent. So what I am essentially trying to say is the Indian Association has come out with some modification and tried to incorporate these newer modalities, that is loco-regional therapy, that is chemoablative therapies and radiation therapy. They try to factor in these specially for intermediate and locally advanced group. Whereas these other classifications like Bclc and all, I'm not able to share this. Just see why I'm not able. This slide I'm not able to share. Just stay there. Just full screen. Just stay there. Can you see it now?
The slides are visible now.
They are visible now and I am audible?
Yeah, slides are visible.
Okay. So now you look at this easel and this, they try to factor in the intermediate stage, you do transarterial chemoembolization, advanced stage, you do systemic therapy. But what this Indian Association modification has done, they have tried to do certain intervention in intermediate and advanced stage, and which has shown that there is a survival advantage. That is basically, if you do these interventions, there is a possibility you may increase the survival advantage if you combine TACE with other therapies also. And let us see the data. So here, this is the modification what they have done. They have done is they have combined not only the focusing on the TACE, they are incorporating TARE, they are incorporating stereotactic body radiation therapy also, which was missing in the other therapy. And there are several systemic therapies now which are emerging. So we have to factor in those things which has not been captured in other classification system. So now how it improves? Now look at the data here. So if you look at the median survival was 16 here in the intermediate stage. So if you see what we call the cure in the early stages, we can achieve by either by ablation therapies or curative resection, by transplant, we can go 5-year survival up to 70%. Whereas if you look at the intermediate stage, the survival advantage, median survival is 16 months, but it's a large group. And if you combine these therapies, if you offer these therapies, that is other therapies like TACE, TARE, and you combine with other therapies and downgrade these tumors, you can achieve a better survival, 5-year advantage, even up to 49%. So this is the advantage. And if in the advanced stage, if you give this newer chemotherapies, so the median survival, which was 6 to 8 months, it can go as high as 13 months. So clearly there is a survival advantage, or median survival is better if you offer this therapy even in advanced stage of the disease. But the problem is, now as I said, so this is the region, this intermediate stage of Bclc is quite controversial and needs several modifications, which other societies have rightly done so. and they believe it is very, very conservative and it doesn't go bleed day, and these patients are quite heterogeneous and the biological behavior of the tumor is also quite variable. So coming just a word about the ablative therapies which we have radio frequency ablation, we have microwave ablation, we have cryoablation, irreversible electroporation, and we have a lot of data which is emerging. And these therapies, they have their own advantages and disadvantages. But of course, the most commonly practiced all over the world is radio frequency ablation because we have a large experience. But now if it is emerging that the other therapies are also being adopted all over the world. Now coming to the surgery, which are the optimal surgical candidate for liver resection? So obviously those who are child A, the child status A, and without ascites, and these are the, because it affects the morbidity and mortality. So these are the patients who are less likely to have poor outcome. So if those who have preserved function, optimal surgical candidate, these are the patients you should be offered resection over ablative therapy. So now coming, because we have two operative treatments, one is resection, one is transplantation. So how you decide? It is primarily based on the extent of resection. If the patients have portal hypertension, depending upon the extent of resection and underlying liver function. If you are planning more than 3-segment resection, means extended resection, the patient is likely to affect the poor outcome. Secondly, if the patient has significant portal hypertension, it have a poor outcome. So likelihood of decompensation will be very high, I mean more than 30%, if the patient have, if you are performing extensive resection, if the MELD score is high, it means poor liver functions, then in end the patient has portal. So you should be mindful when recommending resection in these patients, those who have clinically significant hypertension, portal hypertension, who has a large resection is planned, and the patient has a major resection. So you should be mindful of these. So ideal candidate, again coming to the resection, it is solitary tumor, preserved liver function, HVPG less than 10 means clinically significant portal hypertension should not be there, and the platelet count should be more than, which is a surrogate marker of portal hypertension. So inoperability, of course, anybody who is beyond this should be assessed carefully before submitting based on whatever system you follow, whether you follow Milan, which is the most commonly system for dissection or for transplant all over the world. Now, another concept of liver transplant which has emerged over a period of time is what we call the metro ticket. So metro ticket means the further that you go, the more you pay. So here it factors into two things, whether you can improve 5-year survival beyond Milan criteria, that is what it essentially says. But it is, and what it factors alpha fetoprotein values, it factors the tumor size and tumor numbers. Now, so essentially this is what it is, a modification, or what it improves upon the Milan system which goes beyond the Milan. So this is what it is. Now coming to the other therapies, that is tunnel beam radiation therapy. The patients, as I said, in advanced disease, you can have these kind of therapies where you can give external beam radiation therapy also, which is radiotherapy. So there are different systems of radiation therapy. One is stereotactic body radiation therapy. And there is another thing you can combine with the TACE and other therapies. But the data is still emerging. It is not a clear cut. So what the consensus statement is says that if you do as stereotactic body radiation therapy, it's emerging as a therapy, and they should need further exploration. And especially those patients who Bclc stage B or there is a recurrence, these are the patients who can be benefited by this therapy. Now coming to the chemoembolization, that is transarterial chemoembolization, you can have option of standard chemoembolization technique, or you have drug-eluting beads. So both of these options are available. So you can do conventional way, you can do DAB ways. So the only advantage there, though overall the response or the efficacy of both therapies is similar, but the toxicity is slightly less, side effects are less in the drug-eluting beads therapy. So the thing is, problem with these transarterial chemoembolization or TACE therapies is that it should cannot be used in advanced poor liver functions or do as advanced poor performance status of the patients, where the high bilirubin is there, where the tumor burden is very high, means more than 50% of the liver volume is involved, major portal veins, macrovascular invasion of the major portal veins, so you can't do this therapy. So improve upon that. So the improve upon that, we have other therapies. So can we combine TACE with other therapies? Yes, they have been combined with RFA, they have been combined with sorafenib and other bevacizumab, that is VEGF receptor inhibitor. So, but it has not shown any survival advantage if you combine TACE with these other modalities. Now the another emerging modality is what we call TAR, and it is basically a radioembolization with the radioactive isotope, that is iodine-130 or yttrium. And these are the most commonly used is the microsphere coated with yttrium-90, which emits the beta isotopes. And this is the advantage of it, is can be used, especially those who have portal vein thrombosis where we can't do TACE. It gives a survival advantage, a median survival in this group of patients compared to other group where it was 17 months. It has gone where at another group it was 10 to 12 months. This is useful for advanced HCC, that is stage C, but the liver toxicity is problem. It cannot be given to patients who have lung shunts, who have poor liver function, biliary obstruction, encephalopathy, and of course who has been exposed to radiotherapy before. So that obviously the advantage of TACE, TAR over TACE, it's a low risk of post-embolization syndrome. It can be offered in patients with portal vein thrombosis. It offers better quality of life because its side effect profile is less, and focused delivery of the radio emission, you can decrease the collateral damage is less. Now coming to the last therapies which we offer, this what we call systemic therapies. Systemic therapy is approved here. Earlier it was only sorafenib. Now we have other therapies. This is primarily for stage C disease in Bclc, but in Hong Kong system or INR system, it can be combined with other therapies also. So sorafenib is the first line of choice, and it has shown clear advantage in short trial. Now we have another drug, what we call lenvatinib. It is almost equal efficacy as well as sorafenib, but slightly overall survival is better, and side effect profile is slightly better with the lenvatinib compared to sorafenib. But if the patients who do not respond to these therapy or those who recur on these therapies, then we have newer second line of drugs, what is regorafenib, cabazitaxel, ramucirumab, and nivolumab. These are the new drugs which are still under evaluation, but they are emerging therapies, so we can consider these therapies also. But a newer, this is a recent advancement in systemic therapies, that is atezolizumab and bevacizumab. This has been used advanced unresectable hepatocellular carcinoma in child status patient, good liver function, and this gives clear advantage of sorafenib. So this is a newer therapy, which is this was a recent publication in NEJM, and this is, but of course it's a very expensive therapy. You have to be mindful before recommending these therapies to these patients. So this is coming to the last part, is group of the patients, those who are best supportive care. So what we can offer them, we can make them comfortable as long as with us. If they are in pain, you can give paracetamol, which is the common safest drug in liver disease patients. Avoid NSAID. If you have forced to use of opioids because they can lead to constipation, which it can be troublesome for these group of patients, you should make that they have good laxative, or avoid constipation should be avoided. Codimeds, you have palliative radiotherapy. You should be careful while using benzodiazepines. Nutrition, you should take care. And of course, psycho-oncology is emerging as a therapy. You should offer them palliative counseling also. And so this is the last slide of my talk, that is take-home access. There are several systems which are emerging. However, the Bclc system developed by Spain is the most validated system. When you are operating within Milan criteria, that offers the best survival advantage, but we can go beyond Milan with such of patients which you carefully identify. There is no staging system at the moment which is perfect, but we should apply the system based on our own experience, especially like in Indian setting, we have INSL modification. There are several emerging therapies in stage B and C. The the combining TACE with other therapies have not shown any advantage over the conventional therapy, that is single or monotherapy. There is a good alternative, especially over TACE, if you cannot do TACE because of portal vein thrombosis. So it's a good option, but the cost of therapy is quite different. Immunotherapy is also emerging as a new area which we should keep track of, and I'm sure in future we have a lot of data on this. And of course, radiotherapy is another exciting kid on the block which needs further validation. Thank you very much for your patience. I conclude my talk, and I'm ready to take any question if at all.
Thank you very much, Dr. Rajesh Gupta, for your valuable speech on hepatocellular carcinoma and this management. Now I would like to invite our participant in this question and answer session, please. If there is no question, I would like to further proceed to the next session. Thank you, Dr. Rajesh Gupta again. Now I'd like to invite Dr. Jagadish.
Thank you, Dr. Saeed, and for giving me this opportunity. And I'm sure I've tried to clarify as much as issue, and hope to see you soon. Thank you, Dr.
Yes, sir.
Saeed.
Yes, sir. Thank you, sir. Again, thank you. Now I would like to invite Dr. Jagadish R, Senior Consultant, Intervention and Diagnostic Radiology, Asian Institute of Gastroenterology, Hyderabad, India, to deliver his speech on management of gastric varices and hepatic encephalopathy. Dr. Jagadish, please deliver your speech now.
I hope you are able to see and hear me.
Yes.
So today I'll be discussing about the intervention radiological management of gastric varices and hepatic encephalopathy. As you may be knowing, because gastric varices have been predominantly being dealt till now by I think endoscopy and off late even by endosonography. But there are certain procedures in our intervention radiology armamentarium in which we can deal these gastric varices and at the same time even the hepatic recurrent encephalopathy by a method called as the BRTO or the balloon occluded retrograde transvenous obliteration of gastric varix. So I'll be presenting two video capsules of each case, one of gastric varix and another how we treat a hepatic encephalopathy. So let me present to you initially with a case scenario. So this is a 62-year-old male who is a known diabetic and who is a chronic liver disease NASH related with a MELD of 9, who has been presenting with melinas and hematemesis recently. He has been undergoing glue embolization for the gastric varices in the last 2 months, in spite of which he continues to have this drop in hemoglobin and hematemesis. The present hemoglobin of 11 is after 2 units of blood transfusion a week ago. So let me introduce first to what we are dealing with. Like as everybody knows that bleeding from gastroesophageal varices is a major complication of portal hypertension in patients with liver cirrhosis, where the bleeding from gastric varices is usually less common than from esophageal. But the gastric variceal bleeding, as you know, has a poorer prognosis associated with a more severe blood loss and higher mortality, reaching up to 45 to 55%. So what are the indications for this BRTO procedure? One is the gastric variceal bleeding, which is the impending prior or an active or a refractory debilitating hepatic encephalopathy. So before that, I would like to give a brief overview as to what do you mean by the left versus right portal hypertension so that we get a better idea as to how gastric varices management by IR is more benefited rather by doing just a tips. So one needs to understand that gastric varices feeders are usually the posterior gastric vein or the short gastric vein, which are closer to the gastrorenal stent. Whereas the right side portal hypertension, it is usually the coronary vein or the left gastric vein. It arises in the right side of the circulation. So for a gastrorenal stent, the portosystemic gradient is usually less than 12 mm and a hepatofugal flow in the splenic vein. Whereas the one which is fed primarily from the coronary vein, the gastric varix component definitely will resolve with the tips, and usually they have a higher portosystemic gradient or the HVPG. So the distance between the tips and the portal origin of the posterior gastric vein is equal to usually twice the distance between a tips and a LGV. So I think this proximity theory of left versus right as to how we select the case scenario depending upon the gastric varix presentation, if it is closer, suppose only the right coronary vein is the one which is feeding the gastric varix and with a HVPG more than 10, then definitely tips would be more beneficial. But if it is predominantly towards the left sided, that is through the coronary or through the left gastric vein, then I think BRTO would be the ideal. So just a flow diagram, as you can know. There are two main intradiaphragmatic portosystemic stents. One is the gastrocaval stent, the other is the splenorenal stent. Many of us are very much in with the gastrorenal stent, but there is another stent also, what is called as the gastrocaval stent, which in a carefully done triphasic CT, you would be able to visualize it. So I'm going to just enumerate what are the usual common afferent channels for this gastric varix. One is the coronary vein, as I said. If it is isolated, then tips may be beneficial, or the posterior gastric vein or the short gastric vein. Sometimes all three are beneficial with a gastrorenal shunt. So in such scenarios, you can see even the portal vein caliber will be less. There will be hepatofugal flow. So unless we treat it through a BRTO that is managing these gastrorenal or the gastrocaval shunts, you will never be able to eradicate this gastric virus and improve the blood flow towards the liver. So this is just a flow diagram as to show how the BRTO works or the gastric varix hemodynamics. So I can see the red arrows indicate the inflow and the orange arrows indicate the outflows. So this is how once we cannulate through the transfemoral approach is what we usually do. There are instances where we even use the transjugular approach. So once you gain entry into the left renal vein, you need to cannulate the gastrorenal shunt and then occlude the balloon and do a occlusion venogram, in which there will be opacification of the gastric varix, as you can see. Subsequently, once you can visualize the gastric varix, then you start injecting the sclerosant, or what we call it as either the sclerosant use, nowadays part 2, what we call it as plug assisted, or sometimes coil assisted, what we call as CARTO. But in the management of gastric varix, I think sclerosant in the form of a polidocanol or a tetradicyl sulfate or even bland gel form can be used. So sometimes even after occlusion, you may not be able to visualize the gastric varix. That is because either the shunt is quite wide enough where the occlusion is not good enough, or there must be multiple smaller feeders which you may have to occlude before opacification or visualization of the gastric varix. So once you can see, once we have occluded everything and then you inject the sclerosant, and the end point is once you see the sclerosant going into the systemic circulation, that is the portal circulation. So what's the physiology, what happens following BRTO? One is the diversion of blood flow from hepatofugal to the hepatopetal. It avoids the shunting of the blood away from the liver as you see in TIPS. It preserves the function and also improves the synthetic capabilities of the liver for a period of about 6 to 9 months. There is always a risk of aggravating the portal hypertension in the form of, you may see that there will be multiple esophageal varices. This can be avoided. Bleeding from these varices can be avoided by using beta blockers, by prescribing, and also timely, every 3 months or 6 months, you can do upper GI endoscopy. In fact, by this, you can cut down the bleeding rates due to portal hypertension. So the preservation of the hepatic function is one of the main aims of and the benefits of BRTO by redirecting the blood flow, and also it improves the hepatic function, as I had stressed in the previous slide, for approximately about 6 to 9 months. So what are the pre-procedure imaging evaluation to be considered? So portal vein patency, this is a must. Not completely portal vein thrombosis shouldn't be there. The presence and size of the gastrorenal shunts for conventional BRTO. Alternative portal systemic shunts should also be screened, as I told about the gastrocaval shunts, or sometimes even you may end up doing a BATO procedure. These shunts can be located above or below the diaphragm, and the cross-sectional imaging modality which are to be used is a triple phase CT or a CT photovenography, whatever you call. Coronal reformat should be done so that it acts as a good roadmap for you. Oral contrast agents preferably not to be used, so that they do not interfere with you identifying the vessel apart from the baba. So this is a scale diagram where we are showing just an approach to the transfemoral. We have gained access into the renal vein and the balloon occluding the transrenal shunt. This is a conventional BRTO, where the shunt is not very well seen, that is the splenorenal shunt or the gastrorenal. Sometimes TIPS may not be possible for some reasons. Then you can approach through the portal vein and occlude the left gastric vein or the coronary vein, through which you can what is called as the BATO. There are instances where we have done a combination of BRTO with BATO whenever the sclerosant mixture is exceeding the limit of the total, that is around 30 ml. That is a huge gastric varix when you're doing. The normal sclerosant mixture is the upper limit is 30 ml. That is the sodium tetradicyl sulfate what we use here. What are the contraindications? Chronic portal vein thrombosis, and the relative contraindications are the uncoagulability, splenic vein thrombosis, uncontrolled esophageal variceal bleeding where you can band them and again take them up, intrahepatic HCC of more than 5 cm. So this is the case which I had shown. You can see the shunt with the gastric varix. These are varices with bleeding episodes, what we have seen on the endoscopy. This is seen on the endosonography where you can see the multiple varices. And these are the ingredients which are required for the conducting of a successful BRTO. This is the sodium tetradecyl sulfate. It comes in 2 ml vials. This is a lipidol mixture. Again, it comes in a 10 ml vial. And this we use the conventional stone balloon which is being used in ERCP as our occlusion catheter. Although you get catheters from even Boston's called as the equalizer balloons. So this is the mixture how we prepare it in this ratio: air, sodium tetradecyl sulfate, and lipidol in the ratio of 3:2:1. And this is the case scenario. We have gained the access into the IVC through the transfemoral route. This is the IVC venogram. Subsequently, we will be gaining access into the left renal vein and the cannulation of the gastrorenal shunt. As you can see, this is the gastrorenal shunt where the catheter is being placed. The sheath has been maneuvered into the left renal vein. So this is without the occlusion venogram. As you can see, you are not seeing the opacification of the varix. You are seeing that this is the efferent path, so the contrast will definitely flow back into the renal vein. So in the subsequent, as you can see, this is the balloon occlusion, and as you can see, there is further antegrade opacification of the varices and the shunt slowly as we increase injecting the sclerosant mixture, that is sodium tetradecyl sulfate along with air and lipidol. You can see subsequently it is getting opacified. So slowly, this will take over a period of half an hour. Sorry. So at the end, what we do is either we do combination of BRTO along with CARTO, that is coil assisted. We go ahead and put up the coil so that you can remove the catheter immediately within an half an hour. The procedure would be completed within 45 minutes. Whereas where the coil availability is not there, where what the conventional BRTO used to be done initially, you may have to occlude the balloon for say about 2 to 4 hours unless the sclerosant, everything, all the vessels get thrombosed. Only then you can remove the occlusion catheter. Otherwise, you will see all the sclerosant escaping into the systemic circulation. So as you can see, the subsequent day CT, you can see complete opacification of the varices. As you can see in this grade diagram, with this is a plain CT which we have done the next day, or wherever you have the services of the cone beam CT, you can confirm it on the table at the same time. So this is the subsequent endoscopy done 3 days later. So what's the definition of the technical or the clinical success of our procedure? So the thing is, technical success can be defined as one is the control of actively bleeding gastric varices and the complete thrombosis of the gastric varices. Clinical success, no recurrence or rebleeding from the gastric varix. In the case at-risk gastric varices, no future bleed. There have been multiple studies with meta-analysis to show the importance or the success rates of BRTO, where it has been seen that the technical success rates from in each individual study from 84 to 100%, although the recent studies quote up to 100%. So most common cause of technical failure is usually a large shunt, where you are unable to trap the entire gastric varix. So what are the clinical outcomes? The rebleeding rates, it depends upon what's the definition used. Most studies display a gastric variceal rebleed rate in a patients who had undergone a successful BRTO ranges between 0 to 10%. When you factor it with an intent to treat basis, it extends up to 0 to 31.6%. So this 31.6%, it also includes the esophageal variceal bleed also, what the study quote says. So as you can see, the 19 to 37%, it includes all types of varices, and it includes, in fact, even the esophageal varices, which have not been monitored initially. So this paper dates back to 2012. So you can see again the review and the meta-analysis done in 2015 by Park et al. The technical success and the clinical success rates are considerably quite good enough. The major complication rate in the form of balloon rupture is about 2.6%. you can see the esophageal recurrence rate. This is around 33%. So this has been recently attended to with the help of the prescribed. As you can see, there has been another study by Sabri et al. In whom they are compared TIPS versus BRTO. In this, you can see that although the bleeding source was significantly less, in fact 0% in the BRTO group and absolutely no encephalopathy in the BRTO group, which goes on to show that careful case selection for the BRTO is a must for treating gastric varix, and you can cut down the complications and the further rebleed rates. So I'm taking you to the next case scenario where the patient has presented with a recurrent encephalopathy. What we have done is we did a triphasic CT to look for a portosystemic shunt. Here I would like to stress, do not go only after the gastrorenal shunt. There will be multiple portosystemic shunts in the form of umbilical vein to the iliac veins, sometimes from the SMV to the iliac veins. So you need to carefully evaluate your triphasic CT with the help of your radiologist or an intervention radiologist who would be better off to see where to look for the portosystemic shunts. So we had seen in the CT that there was a large umbilical paraumbilical vein which was extending down and communicating with the iliac vein. So as I would again to reassure that what has to be seen when we are doing for a recurrent hepatic encephalopathy, apart from doing a triphasic CT, look for the port vein patency, the presence and the size of the gastrorenal shunts and alternative portosystemic shunts, which can be located either above or below the diaphragm. So this is we did the percutaneously under ultrasound guidance. As you can see, we have punctured the umbilical vein at the level of umbilicus, and as you can see, it's an efferent, so it's going caudally towards the iliac veins. So after this, we try to gain access into this umbilical vein with a 6 French sheath. We send the wire towards the umbilical vein, and then you can see we have done the venogram. You won't see opacification of the left portal vein because it's an efferent pathway. Then we place a sheath in this umbilical vein and then start occluding it with the help of coil and at the end even the gel foam. You have to come up to that, then the tract embolization happens. That's it. So this patient has been in follow-up for more than 2 years and he has had no episode of encephalopathy and there is no further development of any other portosystemic shunts which you need to look for. So there are 5 studies evaluating patients with encephalopathy in which there has been significant reduction seen in 100% success rate. So largest among this was done by the Fukuda et al. Where you can see the 32 presented with gastric varix and 11 with the hepatic encephalopathy, of which 9 had presented with gastric varix also. So hepatic encephalopathy was completely cured in all patients. So to conclude, I would like to say that management of gastric varix must be tailored to patient anatomy, clinical features and hepatic result, and also take in considerable effectiveness in controlling the gastric varicose with low rebleed rates. You have to control the complications of portal hypertension which happens subsequent to the BRTO with close monitoring with endoscopic follow-up and beta blockers. It can be performed on patients with poor hepatic reserve and encephalopathy. I would again like to stress that the presence and size of alternative portosystemic shunts should always be looked for in your triphasic CT. Thank you.
Thank you very much, Dr. Jagadish, for your valuable speech on intervention radiological management of gastric varices and hepatic encephalopathy. Now it's time for the question and answer session. I would like to invite our participant to participate in this session.
I would like to ask one question as to how are you treating gastric varices? Matlab, is it purely endoscopic or endosono or BRTO are you people doing?
Actually, in our country, we mainly manage gastric varices with endoscopically, by doing injection or even bending. DRTO or interventional radiological management of gastric varices and hepatic encephalopathy is not widely available in our country. I would like as there is no question, I would like to again thank Dr. Jagdish to present his excellent speech on this management of gastric varices and hepatic encephalopathy. I would like to again thank you and like to end this session. And now I would like to invite Professor Mamunal Mahakar Shopil sir, Chairman, the Department of Hepatology, Bangabandhu Sheikh Mujib Medical University, to give his speech on innovative interventions for liver diseases. Professor Mamunal Mahakar sir, please.
Thank you for the. I think you can see my slides.
Yes, sir. But we all were seeing your slide. Please continue.
Thank you all. First of all, I would like to thank Dr. Nageshwar Reddy, Dr. P. N. Rao, and the entire AIG team for very kindly collaborating with the Forum for the Study of the Liver Bangladesh and BSM Hepatology Alumni Association for organizing this series of eSPACEs. I'm also grateful to Sun Pharma for providing the technical support. So over the next few minutes, I will guide you through the stem cell transplantation and stem cell therapy that we are offering to our patients in Bangladesh for acute and chronic liver failure and chronic liver disease who are decompensated. So showing back the very old slide that the liver regenerates is not something new that we know today. It has been mentioned in the Greek mythology. And why do we need hepatic regeneration? We know that the liver has the enormous regenerative capacity, but there are still certain conditions where in the setup of chronic liver disease or acute and chronic liver disease, when the regenerative capacity of the liver is overridden, and then we need to induce the regeneration. So the most established way of regenerating is by in vitro procedure, that is liver transplantation. But in a setup like us, where we don't have a transplant program, we always look for alternatives. And so the alternative for us is a rather developmental or conceptual procedure, which is in vivo regeneration by stem cell transplantation. So by to induce in vivo hepatic regeneration, we can do it by two ways, as the published literature suggests, or we can try to do it by two ways, I should rather say. One is by indirect stimulation of stem cell production, and the other is directly by transfusing stem cells. So this comes from the very fact that if we inject granulocyte colony stimulating factor, that will help mobilize stem cells from the bone marrow to the periphery. And this elegant paper by Professor Sarin's group actually shows that this can be done. We can mobilize bone marrow stem cells to the periphery by injecting granulocyte colony stimulating factors. And first I will talk to you about ACLF. So how does it help in ACLF? What happens in ACLF is that an acute insult results in sudden and acute decompensation of a previously diagnosed or undiagnosed chronic liver disease. And one of the mechanisms in the pathogenesis of ACLF is neutrophil dysfunction. It has been proposed that Gcsf restores neutrophil dysfunction, prevents sepsis, and hence the downhill course of ACLF. And this paper by Professor Sarin also proposes that if we give Gcsf, in addition to prevention of sepsis, there is increased trafficking, proliferation of hematopoietic stem cells in the bone marrow. There is increased cytokine production, reduced apoptosis, which leads to increased CD34 cell count, neutrophils, monocytes in the peripheral blood, and eventually the prevention of sepsis, and these beneficial effects result in increased hepatic regeneration as well as reduced hepatic fibrosis and inflammation. And possibly this is how stem cells help the liver in ACLF and in chronic and in decompensated liver cirrhosis. So this was a paper by one of my junior colleagues, Dr. Biplab Shah from our Department of Hepatology, where we actually studied the effect of Gcsf in acute and chronic liver failure. And what we did was we injected Gcsf 30 IU once daily for 6 days. And we did notice improvement of MEL score in the patients at 90 days follow-up. And more importantly, there was some survival benefit, although it was not statistically significant, but we did see improvement of MEL score and survival in patients with ACLF who are on Gcsf compared to standard of care alone. And this is a very, and when we look into the literature, we see that both from India, Garg and colleagues, and from China, Duan et al., have actually shown similar data, showing that Gcsf in ACLF helps in improving survival, in improving MEL scores, and Garg et al. Actually went on to add that there was reduced sepsis, HRS, and hepatic encephalopathy in ACLF patients with Gcsf administration. And this is a very recent paper by another junior colleague, Dr. Nazmul Haq, where for the first time, I think in the literature, we have applied a combination of Gcsf and erythropoietin versus Gcsf in ACLF patients. And here also, if you can see that we have seen survival benefit in patients who received a combination of Gcsf and erythropoietin at 90 days follow-up, not to mention that the MEL score also improved. Although these were not statistically significant, but we did see benefit, and these are encouraging results that encourage us to go ahead with such studies. Here also the dose of Gcsf was 5 microgram per kg per day for 6 days, and erythropoietin injection was given at the dose of 40 microgram per kg per week for 4 weeks. So this is our experience with the ACLF, where we are seeing, with the Gcsf and the erythropoietin in ACLF patients, if we can address the issue during the golden window period of 7 days, then possibly this helps, which is supported by the published literature to some extent. Now, going on to decompensated liver cirrhosis, there are many publications in the world literature where you will see that there have been reports. This is not yet an established modality of treatment, stem cells for chronic decompensation, but there are the reports that at least it is safe and possibly the approach helps patients. And actually, there is another paper which says that autologous bone marrow stem cell transplantation actually results in improvement of a coagulation profile of cirrhotic patients. The benefit is seen 2 to 4 weeks after the autologous hematopoietic stem cell transplantation and lasts for 24 weeks, but usually not more than 6 months. So we cannot say that this is a curative treatment option for patients with liver cirrhosis, but we can surely say that this may be a good way of, bridging to transplant. So when we went on stem cell transplantation, we wanted to progress step by step. So first, to establish the safety, we did a small study in a group of 18 patients with decompensated cirrhotics who received a Gcsf at 30 IU into 2 once weekly for 6 weeks. And we wanted to see what happened. So we saw that like in ACLF, in decompensated cirrhosis also, Gcsf was safe because we did not notice any adverse event in any of the patients, and most of the patients were actually alive at 90 days. So then we were a bit more, what should I say, enthusiastic, and we decided to go for proper stem cell transplantation. So what we do is actually we stimulate our patients with Gcsf injection. The dose is injection Gcsf 30 IU per daily for 6 days. Here not weekly, but for daily injections. Okay, and then what we do is we did our first case on 12th February 2018. So you see the first case here, the first patient, we are doing it, and this is how we do it. We use an apheresis platform to collect the stem cells after Gcsf injection. This is how it looks. So now there may be a few questions that what is the cell count? So we have used flow cytometry to have a cell count, and we have seen that the stem cells that we transfer is 7.5 into 10 to the power 5 per ml on an average, which is considered by the hematologist to be adequate. We also have looked into the viability of the stem cells that we transplant in our setup, and we have seen that the viability is well. So we can confidently say that we stimulate stem cell by Gcsf, we collect them, those are viable in adequate numbers, and then we deliver them. So initially, we were delivering these stem cells by the TASE technique, the transarterial chemoembolization technique. The same technique we go to the cath lab, cannulate the hepatic artery and deliver the stem cells. And based on this, we have presented several conference abstracts. Here is a list of some of the abstracts that we have presented in different national and international conferences. And subsequently, we published our experience last year, where we actually have seen that with this approach, that is with autologous hematopoietic stem cell transplantation, there is improvement of bilirubin, albumin, and prothrombin time. ALT normalizes, creatinine improves, but the significant improvement has been seen with ascites and albumin. So this is very encouraging that we saw that patients do benefit at 90 days with standard of care plus the autologous hematopoietic stem cell transplantation, those who have decompensation of liver cirrhosis. And then we thought that it is a bit challenging, going to the cath lab, the taste, it is becoming a bit challenging, and also the cost effectiveness was an issue. So then we adopted a new approach. Now what we do is we collect the stem cells the same way. We stimulate the patient with autologous with Gcsf injection after repeated doses. We then collect it with through the apheresis platform. But instead of then going into the cath lab, we go to the percutaneous approach, and under the ultrasound guidance, we delivered the collected stem cell in the portal vein. So we did the first case approaching the portal vein on August 2018. And very recently, we have published our first set of patients, where we again see that at 90 days of follow-up, there is improvement of bilirubin, albumin, prothrombin time, and ALT normalizes, creatinine also improves. The finding is comparable to the finding when we use the transarterial route. We actually expected a better finding when we approach the portal venous route, because the portal venous blood flow is slow, and also it is the main supply to the liver. But again, that was not established, but at least the findings were similar. But this is the portal venous approach, is a percutaneous approach using the ultrasound guidance instead of the cath lab being needed. So we thought that this is encouraging stuff. So the things that we have been doing has been attracting quite some attention in local media. And we have actually constituted a Bangladesh Stem Cell and Regenerative Medicine Society. And under the agencies of this society, we have the StemCon, or the Stem Cell Annual Conference, every year on 26 December. This year is the birth centennial year of Bangabandhu Sheikh Mujibur Rahman, Father of the Nation of Bangladesh. So this 26 December, we have the fourth StemCon, which will on virtual platform. We have named it after the Father of the Nation, Bangabandhu StemCon 2020. We'll send you invitations, and we'll expect your participation there, where we will showcase the stem cell research and treatment in Bangladesh and beyond. And we are very honored that the Honorable Prime Minister of Bangladesh has issued a special message on this occasion. So hopefully see you all in StemCon 2020, Bangabandhu StemCon 2020, and thank you very much.
Thank you very much, Professor Mahmood Al-Mahatab sir, for delivery your speech on innovative interventions for liver disease. Now the session is open for question and answer. One question is from Dr. Abu Hayat Malik. Maybe this question. He delivered this question to Dr. Jagadish. As Dr. Jagadish lead the session, the question is endoscopic obliteration or BRT obliteration of gastric varices. Which one is superior? As Dr. Jagadish is not available, I would like to answer the question to Dr.
Yeah, Dr. Jagadish is available. I think he can answer.
Yeah.
Can
you repeat the question?
Is obliteration of gastric varices by endoscopically or BRTO technique, which one is superior? Is there any studies?
Yeah, there are studies, and in fact, many studies which are quoting. See, when we are doing the endoscopic, the thing is we are seeing only part of the varix which is visualized on the submucosal surface. Whereas, as you can see in the BRTO or subsequent to your imaging studies, you can see the shunt and the amount of collaterals which are leading up to the shunt. So, we will be doing by endoscopy only the varix which is seen. So, but once the varix is seen, the hypertension still persists. So, the pressure is still there. So, there is subsequent, maybe a month, 2 months down the line, you will see another varix which will be coming just adjacent to this. Whereas with BRTO, what we are doing is we are completely avoiding this hypertension and redirecting the blood flow to the portal vein. In fact, decreasing the left-sided hypertension and diverting the blood towards the liver, making it more towards the portal hypertension. And in fact, that's why esophageal varices come. So those esophageal varices can be decreased with the help of good follow-up with endoscopy and beta blocker. So in fact, there are studies by W.L. Saad which categorically states that you do a good triphasic CT just before you take the patient for an elective gastric varix embolization, so that you get to know the anatomy as to how good, and accordingly you can prognosticate the patient. So I think BRTO definitely holds a place in the management of gastric varix.
Okay, so thank you for your valuable comment. Now, I thank all the three speakers, Dr. Rajesh Gupta, Dr. Jagadish, and Professor Maunal Mathur sir, to deliver their valuable speeches. Now we would go to the next session. Next session will be conducted by Dr. Roxana Begum, Assistant Professor, Department of Hepatology, Shohid Sohrawardi Medical College and Hospital, Dhaka, Bangladesh. I would like to invite Dr. Roxana Begum, please conduct the next session.
Good afternoon, dear audience. Thank you, Dr. Faiz, for giving me the floor. We are going to start second part of our today's session, that is live workshop. And live workshop organized by Asian Institute of Gastroenterology. I would like to request the AIG panel who will conduct the live session to introduce themselves. We are going to start second part of the session, a live workshop by AIG. Is AIG panel available here? I would like to request AIG panel to introduce themselves and start the session. I think they are coming live.
Oh, ये वाला टेबल देख सकता है ना? देखो.
We are on the way to start the session.
Any issue?
The live session will be
Hello,
started
Mr.
very
Sir.
soon.
Mr. Satya?
I am Dr. Musamud Roxana Begum from Bangladesh. Request you all to keep patience before going there.
Good morning. We are live from AIG Hospital. My name is Dr. Anirudh. We are going to demonstrate few interesting cases today. So first case is middle-aged male who presented with history of hematemesis 1 week ago, was admitted elsewhere and was managed conservatively. There was significant drop in hemoglobin and also bilirubin showed a predominantly direct elevated bilirubin Upper GI endoscopy showed fundal varices with signs of recent bleed. So plan is to perform an endoscopic glue injection. Over to Dr. Mohan.
Good morning. Can you hear me?
Yes, we can hear you, but the sound should be more clear.
Okay. देखो. So you heard the history. This is a patient with portal hypertension and has presented to us with hematemesis. He had esophageal varices and fundal varices. Esophageal varices were banded, and now he has been referred for management of gastric varices. And management of gastric varices has changed a lot since say last 4-5 years. The major advancement being two. One is introduction of interventional radiology, and you heard Dr. Jagdish how they have helped us a lot in managing gastric varices, especially BRTO, and of course TIPS remains the ultimate option also. But in our day-to-day clinical practice, we use more easily available, and since IR team is not that available more commonly in remote areas, endoscopy is definitely a better option once we are considering out of institutes management of gastric varices. And one should be very well versed with endoscopic management of gastric varices. So the first thing which is the normal endoscopic obliteration of gastric varices by glue, which I will be showing, but also we will be knowing about what are the other endoscopic options available. So before attempting to do glue injection, we will concentrate on our armamentarium. Of course, we should have a very good technician like Naresh with me, and a very good anesthesiologist like Dr. Srinivas with me. They form a very important team members, especially to keep the patient properly sedated, that they should not move while we are injecting, because it's a very high pressure zone, and if patient moves, we may cause some injury and more bleed rather than stop bleed. And Naresh will help me in injecting the glue, and we have ready with us. This is the glue which I will be injecting. So I have filled up glue with 1 cc, and also I have a lot of spare glue available, but all in aliquots of 1 cc, not more than that. So I will be injecting 1 cc at a time. I have many syringes filled up with distilled water. So we should always use distilled water. One is 2 cc syringe, which I will be using, and also 5 cc syringe. The 5 cc syringe is for flushing, which I will definitely demonstrate. And then I have many glues which are available, and also many injectors. So these are endoscopic injector. This is 21 gauge needle, and these needles have dead space. So we have 1 cc injection, but the dead space in this is 1.5 cc. So if you inject and do not flush, the whole glue will be only deposited in the needle. It will not go into the varix. So this has to be always thought in mind, that we have to inject glue followed by distilled water. That is foremost. And also we should have ready acetone. This acetone is the solvent where the glue can dissolve, and inadherent injection of glue into the scope will damage the scope very quickly. So we should always keep acetone in our hand to prevent clogging of our therapeutic channel of the endoscope, and if it gets clogged, the repair is very, very costly. So this is the armamentarium we should be ready with while we are injecting glue. So first of all, you have to remove air from this needle. So Naresh will inject distilled water around 1.5 cc till till it completely wets or remove the air from the needle. So you can see he is injecting, now water is coming out, that means needle is well flushed with distilled water. So now this is ready. So we will inject and we will introduce our scope and see what is there. So you can see now we are seeing some esophageal varices. These are esophageal varices, but this is scarring. You can see post bending scarring over there. Can you hear me? And you can see post EVL scar. This is the post EVL scar and ulcer. And then we go into the stomach and we find hypertensive gastropathy, the snake skin appearance. And then we retroflex our scope and we can see these are the varices. You can see here. So these are fairly medium-sized varices, not very large. If there are large varices and if it requires to be obliterated by a larger volume of glue, now glue is liquid. As soon as it comes in contact with blood, it solidifies. But it takes time to solidify, 2 to 3 seconds. And if we inject too much of volume in a glue, in a varix, the blood flow will take this liquid glue to remote organs, including the vital organ like brain. If there is patent foramen ovalis, then it may cause severe adverse events. So if the glue is injected only 1 cc slowly, then we can prevent these complications. But if there is a large varix and you are anticipating larger volume of glue to be injected, don't use only endoscopic treatment. Use endosono, because in endosono guided you can also obliterate the varix by coil. And if your coils are injected into the varix, they form a scaffold for the glue not to embolize to different vital organs. So if medium-sized varix are there and anticipated volume of glue is less than say 3 ml, I'll use endoscopic treatment. And if the volume is more than that, I will use endosono first to obliterate the varix with coils, followed by injection of glue. But if I do a CT and find a good shunt, splenorenal shunt, then I will refer these patients for BRTO, because that is more safer. So in this patient, endoscopic injection of glue is ideal, because these are medium-sized varix and I am not anticipating a large volume to be injected. So first of all, I will introduce the needle and palpate this varix. You can see these are the areas where the varix are very, very soft. So I have marked this area with some red color signs also to inject the glue here. And then after injecting 1 cc, I will come back and again palpate and see whether there is any other area of soft varix where I need to inject. The first thing which you have to do is you have to bring out the needle. Bring out the needle, please. Then inject the distilled water to see the patency. See that the needle is patent. So now I will inject this and insert this needle into the varix like this. And then we inject the glue, injection of the glue, please. You see that glue is now accumulated in the needle. So we flush it out with the distilled water, and he is injecting the distilled water. Keep on injecting, yes. So now the glue has gone into the varix. Now you withdraw the needle, and then you flush it with more glue. It's like, okay, stop. So now we'll palpate this
varix by sheath of the needle, and you can see it has become stony hard. See that? That's a stony hard varix. So the glue has completely obliterated this varix. We go to this varix and see this is also has become stony hard. See that? That's all like a concrete ball now. There's nothing. So I think with the injection of 1 cc of glue, some of the glue is protruding out. So we'll just don't suck, straighten the scope and bring the scope out. Suck out all the air. Don't suck the fluid. Suck out all the air. And then you can see here how the needle is being withdrawn. The first sheath of the needle is being cleaned by acetone so that it does not, there is no trace of glue onto the needle sheath, and once it is done, I pull out easily. And make sure that the channel of the scope is not blocked. So this is how we do the glue injection. Any questions we can definitely answer. I can't hear anybody.
Thank you, AIG Group, for your nice presentation. I
Okay.
think there is no question from the audience.
Okay.
Uh,
So that means we'll move to the next case. Anirudh will tell the history, and then Dr. Sandeep will demonstrate that a very interesting case. This case is a case of 37-year-old male presented with fatigue, weakness in 3 months. Liver function test showed a elevated bilirubin with mildly raised AST and ALT. Viral markers are negative. Autoimmune markers are negative. Serum ceruloplasmin was borderline. Serum total albumin was more than 1.1 times upper limit of normal. Ultrasound abdomen showed mild coarsening of ecotexture. Upper GI endoscopy screening showed no varices. So plan is to do a US guided liver biopsy to rule out any evidence of autoimmune hepatitis. Over to Dr. Sandeep. Hello. Good morning. Can you hear me? Hello. Can you hear my voice? Hello.
Yes, we can hear your voice.
Okay. I am Dr. Sandeep Laktakia, and today with me is Dr. Mithun, and I am ably assisted by Dr. Tejas for anesthesia. Dr. Mithun is a hepatologist, and he is looking after this patient. The plan is to do liver biopsy in this patient by EUS guidance. I am sure you must have heard about the percutaneous liver biopsy, which we have been doing for almost more than 50 years. The other way to get liver biopsy is through transjugular route for patients who have ascites and coagulopathy. This is a new method of acquiring liver biopsy by which we use EUS. Do you have the EUS image on the screen? Yes, I think you can see on the right panel. So I am using a linear EUS scope, and this is the left lobe of the liver. You can see the pulsatile heart, which is sitting on the left lobe of diaphragm. So that's the left lobe of diaphragm, left lobe of liver, and pulsatile heart. If I pull back the scope, you can see the heart very nicely. The left ventricle. Okay, so we'll come back to the liver, and these round structures with white margin are the portal vein radicals. Normally this whiteness is much less in a normal scenario. This patient has more thickened portal vein radical. I'll put a Doppler on that, and you can see blood flowing through it. As I rotate around, you will see the blood flowing through it. Also, so this is portal vein radical, this is portal vein radical, this is portal vein radical. This is a hepatic vein, this is a left hepatic vein, which will go into the IVC. If I'll trace it back up, can you see that?
So it's joining with another vein here, and this is going inside the heart, and that's the right atrium. So the hepatic veins join together, or individually they can open to the IVC, and that opens into the right atrium, continues to the right atrium, which is here above the diaphragm. So EOS can be very good modality to look at Budd-Chiari syndrome, where hepatic veins are blocked or not. If we rotate around, we can see rest of the liver as well. So that's the portal vein here. Can put a Doppler on it. So this red thing is the portal vein, which looks little prominent, more dilated. The arrow is on the portal vein, and this is about 13.6, which is more than usual. Other structure that you see, this is the head of the pancreas, this is the neck and the body of pancreas, this is the PD here, and we can see the entire pancreas from the stomach. And that's the pancreatic duct, which is a normal duct. But the parenchyma looks a little heterogeneous. He's a non-alcoholic patient with some changes or alteration in the ecotexture of pancreas. So coming back to the case of doing an EOS liver biopsy. Mithun, do you prefer percutaneous or do you prefer EOS now?
So after the starting of US liver biopsies, we have mostly shifted to US guided because of there are 2-3 advantages which I feel. One is that the amount of pain the patient feels during a percutaneous is less because here we have the patient sedated. And we are taking biopsies now from both the lobes of the liver, the left lobe as well as the right lobe. And we are trying to see whether the results are similar between the left and the right lobe. Also, the initial experience has been very good. We have been getting good number of portal tracks, and we have been able to reach a diagnosis in almost all our patients with US guided liver biopsy. Also, I feel that because it's under direct visualization, sometimes we can avoid the blood vessels, and the chance of bleeding is significantly less, though a head-to-head trial is underway to compare between percutaneous and US guided biopsies.
Thank you, Mithun. So if the cameraman can focus on my hand, this is the device I will be using. It's called an EOS FNA needle, and this is the widest gauge available. This is a 19 gauge needle, which will go through the channel of the echoendoscope or EOS scope. We'll fix it at the hub, adjust the sheath which is projecting out, and then come back to the area of interest. So I'll first take a biopsy from the left lobe. I want to avoid the portal vein radicals and also the hepatic veins. So I'll just talk a little bit and get the best window of opportunity. Of course, I will use Doppler to avoid even smaller vessels. So I think if my needle comes from here and I go through this area, I think that should be fine. Although there is a small vessel in the gastric wall as well, which also I'll try to avoid. So the gauge to gauge the percutaneous needle is a little wider gauge, but rest of the procedure looks much better, easy and comfortable. Plus, we do not go through the intercostal space compared to percutaneous liver biopsy, because sometimes bleeds can happen from the intercostal space. Also, we see the vital structure of hepatic veins and portal veins, we avoid that, and the bile ducts also, if they are dilated. Okay, this looks fine. So I'll just puncture it now, remove the Doppler. So you can see this needle has now punctured the capsule of the left lobe of liver. Now I'll request Sridhar to pull back the stylet, and when he pulls back, so the space is created in the needle, I'll make a jab then and go down. Liver is a huge organ, and he can keep pulling. So he is pulling the stylet, so creating the space in the needle, and I will keep moving in and out 3 or 4 times with a jab inside. So before I pull out the needle, I'll again start the Doppler. The reason is sometimes they can be bleeding inside, which I can actually see real time. So I'm following the tip of the needle, which is here. This is the tip of a needle, and as it comes to the capsule, is there any blood vessel? No, look at this. There is a blood which is tracing to the tip of the needle. So at this time I will stop. I will not move my needle back and let this clot, this tract will get clotted. Liver is a very vascular organ, very well supplied with portal vein and the hepatic artery, slowly this will disappear. This tract clots off, and then as I come out of the capsule, I would pull it out. We will now expel the material and show you how much we got. Can somebody hold this? Thank you. Style it. थोड़ा सलाना डालो. ओ स्मूथ वाला नहीं, बस ठीक. एक स्मूथ वाला है पेटी डिश. पेटो he is pushing back the stylet in the hollow of the needle to expel the material which is trapped inside. So here you see good core which has come out. Put more. Now a long core. Okay. Stop. So if the cameraman can focus, or I don't know whether you can see it or not. Needle say, I'm not sure. So that's a big little core, and you can see a brownish tissue as well, which is a good tissue. Very nice. So it has both the blood clot. So half is liver tissue and half is a blood clot. That's a good amount of tissue that we've got. Maybe one more pass we can take and that should suffice. Plus we can also take from both right and the left lobe. The left lobe we take from the stomach, the right lobe we take it from the duodenum. So could you see that? Could you see the tissue which has come through the liver biopsy?
Yes, we can.
I'm not able to hear, so I'm not sure whether you're listening or not.
We can hear you, and a large spore of tissue has come out. It's really praiseworthy.
So I could faintly hear you, but the tissue core is quite nice. We'll take one more pass and I think that should suffice. So that's a major advantage. You can access a large amount of liver, both left lobe and right lobe. You can avoid intercostal vessels. You can avoid major vessels because you're seeing real time. And plus it's a painless procedure. The visceral peritoneum is painless, whereas parietal peritoneum, which covers the capsule of the liver outside, has pain sensation. So all those things can be avoided. Of course, we observe these patients like routine after any liver biopsy for a few hours. Still it. Okay, so there comes a needle inside, and then I'll make a jab further. We'll keep pulling back, and I will make a jab. 1, 2, I can move around and change the direction. 3, 1 more, 4. Get the flow back on the needle, on the path of the needle, and see any blood is coming back. There is none this time, a little bit. Can you appreciate that this track of blood which is coming back and then it disappears? It's still there, but slowly it will disappear. So we will expel this material again on the petri dish, and may I request the sister to just hold it, please, or hold the bioscope. Yes. तो बंद कर दो. We're just waiting for the tissue to come out. Yeah, here it comes. It's a coagulum kind of a thing. Yeah. So we got some threads again. Okay, so that's a tissue here. You can get good thread here again, which we can. Yeah. So line up. Okay, so that's the tissue which I have. Can I put in the bottle again? Same bottle. So we've got two passes, both from the left lobe, which have got good tissue. And this will now go for pathology. I think with that we complete the procedure. Any questions or comments we can take up?
Thank you, dear AIG team, for your nice presentation. In Bangladesh, we are not habituated with US guided liver biopsy, and we follow percutaneous route. And I had a question to make that.
Your voice is very faint. Can you increase the volume from that side?
Why do you like EUS procedure rather than percutaneous? But Dr. Mithun has already answered the question. So there is no question from the audience.
Okay.
And thank you for your nice presentation.
Thank you very much. Thank you very much for your patience.
Thank you. So this is time for our panelists. I would like to request Dr. Mohammad Jahangir Alam Sarkar, Associate Professor and Head of the Department of Hepatology, Surrey Medical College Hospital, to deliver his valuable comments regarding these patients.
Machine.
Yes, we can hear you. Yes, we can hear you.
Thank you. Thank you, Dr. First of all, I want to thank Dr. Rajesh Gupta for presenting the page a systematic approach to management of HCC. He discussed very brilliantly and he compared different stage systems of Hepatitis. There is emphasis that a hands-on staging system is better than a conventional staging system. According to that, Dr. Rajesh adopted international radiological management of vestibular and antibody. This is very important. He concentrated on the BRCA, management vestibular, which is the combination of inject brain injection. Last figure was Professor Narayana Nayak Specialist, who is the pioneer of intervention hepatology in our country, Bangladesh. He doctors the constant therapy, especially on the HLA patient of decomposite patient. Before 90 days, outcome of the patient to giving therapy, or the biological measures are improving, like breathing, estimate time of activity, as well as this is the SIT. So this is the pathology method, especially to give to the liver transplantation. That's why the validation was excellent. Here, the strict very good management was showed by injection load, and another was endoscopic ultrasound guided liver biopsy. The process was very efficiently and very much highly profitable procedure. Thank you all.
Thank you, Dr. Jahangir Alam Sarkar, for your valuable comments. We are almost at the end of our session. Another panelist, Dr. Sheikh Mohammed is absent today because of his father illness. So we are going to request Dr. Mr. Shpanjal Bosu from Sun Pharmaceuticals to deliver vote of thanks. And I am going to say goodbye. Thank you all. Thank you again. Mr. Shpanjal Bosu.
Thank you. Once again, regards. Eminent panelist, Dr. M. A. Rahim, Dr. M. D. Jahangir Alam Sarkar, and Dr. Sheikh Mohammed Nure Alam Yu, and all our most valuable physicians from Bangladesh. On behalf of Sun Pharma Bangladesh, I would like to extend my sincere gratitude to all of you for your gracious present in this live webinar on eSPACE Endoscopy Masterclass Session 8. I'm sure all of you will join me in thanking Dr. Rajesh Gupta, Dr. Jagdish, Professor Dr. Mahulal Mahtab, Swapnil, and Team AIG for their excellent presentation as well as demonstration on live procedures. Special thanks to Mr. Satya to provide us all the technical support for this virtual session. Also, very special thanks to Dr. Syed Abdul Faiz and Dr. Roxana Begum for moderating today's event in a seamless flow. I would also like to profusely thank, on behalf of Sun Pharma, all the participants present here for gracing this occasion in spite of this challenging time and your busy schedules. It was indeed our privilege to have you all here today. Also, let me thank you for continuing your confidence in Sun Pharma products and extending their benefits to your patients for so long. Thanks a lot for your great support all these years. Thank you all for being our nation's guiding light in the face of this adversity. Last but not the least, I would like to extend my sincere gratitude to all my fellow colleagues, a team of motivated and dedicated assets of Sun Pharma. Thank you, Team Sun Pharma. Thanks. Have a good time ahead and wishing you all a very good day and a safe time ahead. So once again, we will meet on the next